Strive 2 is the standards for reporting of vascular changes on neuroimaging, version 2. And I have nothing to disclose for this presentation. So if you talk about Strive, it's mostly about cerebral small vessel disease that, of course, you all know. But let's ask again, why do we need standardized criteria for describing imaging in small vessel disease? And that goes back to Strive 1 more than 10 years ago. So the main motivation. And that was this highly variable terminology we were using. So for example, as you can see, these two lesions here, pretty straightforward, two holes in the brain. And we had at the time more than 150 terms for a hole in the brain. And not even that, even if we used the same term, there was quite disagreement among experts. This was a survey that the group of Joanna Wardlaw conducted before Strive 1 with a straightforward question. Is there a lesion in the right hemisphere consistent with a lacunar infarct? And you can see in the upper example, there was quite a consensus. Most experts said, yes, definitely. But in the lower picture, there was quite some disagreement among experts, with also many saying no. And by now, you might have realized that these two images are not two different patients. It's actually the same lesion, just at two different time points. Again, adding to the confusion of these highly variable terms. And it's easy to see why this is a problem for scientific progress. How can we do any cross-study comparisons if we're not speaking the same language? Pool our data, perform meta-analysis. I mean, we would pool many different things if we're not speaking the same language. So any large-scale research is really, has problems if we're not speaking the same language, so a real roadblock for this kind of research. So that's why in 2012, Joanna Wardlaw, Eric Smith, and Martin Dichgans brought to life the Strive initiative. It was a small group in the beginning, which grew over time. And you might be familiar with the main outputs of Strive 10 years back, so certainly the main paper in the Lancet Neurology. But there were also many spin-off initiatives, bringing this big group of cerebral small vessel disease experts together. There was also then meta-cohorts and Harness, which focused more on the development of biomarkers. And the main paper was by now cited more than 4,500 times. And from the increasing citation numbers over the last years, I think you can see that there's still a considerable interest in this work, and we still need this. So from the Strive 1 paper, you might know this figure. So summarizing the main lesion features, and of course there were also text definitions for those features. So now why Strive 1? Where does the need for Strive 2 come from? Now, first of all, the question, has Strive 1 actually been well adopted? So what we did it have an impact on the field? And certainly within 10 years, there were some developments. So we need to provide some updates on existing features, but also describe and standardize new and emerging features. Also combined features, so combining multiple features into a score, became quite popular over the last 10 years. And there was certainly a paradigm shift from lesions to more quantitative imaging, so brain structure and function. And of course, also there were developments in acquisition and analysis methods that needed to be covered. So we convened a group of 54 international experts working in imaging in cerebral small vessel disease, and we organized in working groups. So here in blue, you can see highlighted the work group leads. Later in the process, we added some external advisors to again give us some fresh views, and those are highlighted here in green. And again, this initiative was coordinated by Joanna Wardlaw, Eric Smith, Martin Dichgans, and myself. So this started all in May 2021. The process overall was a bit longer than for Strive 1, mostly because of the pandemic, and there were no face-to-face meetings, so all was done virtually, which was a bit challenging. But we had a kickoff meeting, we were then working in groups, had a second meeting to kind of align and find a consensus, and then wrote the manuscript, which was published in May 2023. And the work groups covered the following topics. So 4 work groups covered updating what was already available in Strive 1. And then we had 4 work groups covering new features, new lesions, these combined scores, and the more quantitative imaging. And 2 groups updated our method section. So let's have a look at the first question. Was STRIVE-1 and what was proposed in STRIVE-1 really adopted in the community? And on the right, you can see that the STRIVE term white matter hyperintensity was well adopted. It's now the predominantly used term for describing these flare hyperintense lesions. Also, the term lacune is now the predominant term for a hole in the brain, finally outpacing the lacunar infarct or infarction. But you can see one STRIVE term here at the bottom, the recent small subcortical infarct, and that was not taken up by the community or not well taken up. So this was certainly a main point of discussion while developing STRIVE-2, and there were very controversial views, and at the end in our consensus meeting we had to put it to a vote, and I show you the result of this vote here. So after a lot of discussion, this term recent small subcortical infarct was still the preferred choice of most of our members, but you can see there was still some disagreement and there were certainly some proposed alternatives. So given this vote, we for the moment in STRIVE-2 will stick with the recent small subcortical infarct, and we hope with better explanations and better definitions that we can accelerate the use of this term. So why did we not use the recent lacunar infarct, as this seems to be the second most popular choice? Well, this is because of the variable appearance of these lesions over time. So here you can appreciate from left to right the kind of acute or subacute phase and then the chronic phase, the old lesions. And while they are fairly homogeneous in the acute phase, so this DWI lesion, then over time there can be many different fates. Certainly cavitation, full cavitation into a lacune, but also partial cavitation and small cavitation that is not covered by our lacune definition, no cavitation at all, and also some recovery, so you don't see anything of the lesion. So by calling these lesions in the acute phase a lacunar infarct, you imply that they will develop into a lacune, which actually most of them do not. So that was the main argument against calling them a lacunar lesion or lacunar infarct. Now, STRIVE-2 now appreciates more clearly or more explicitly that all these lesions that you can see here are of course found in small vessel disease, but are not specific for small vessel disease. So they are certainly other causes, like for example, embolism of course, of proximate arteries or the heart. And while there are some characteristics that allow you to perhaps differentiate whether this is more related to small vessel disease or another cause, these are certainly not perfect classifiers. So this is the main output of STRIVE-2. So you see we expanded a little bit our main figure. The addition here is the cortical superficial siderosis, as well as the cortical cerebral microinfarct, which are the new lesions. And it's important to note here that all the definitions and what you find in STRIVE-2 should always be used together with STRIVE-1. So we encourage to read both papers and actually use definitions in both papers, as long as they are not outdated or superseded by STRIVE-2. And of course, there are also text definitions, especially of those features that are not included in the figure, and that's brain atrophy. Again, certainly not a specific feature of small vessel disease, but one of the features. And these combined scores, so when you take multiple features and you summarize them in one score, and the group proposes to call this a summary small vessel disease score. For example, not total small vessel disease score, because you're probably never able to really quantify the total small vessel disease. So let's move on to emerging features, and the most prominent here is the incidental DWI positive lesion. And you will immediately see there's of course some overlap with the recent small subcortical infarct. So imaging-wise, they can appear very similar. The main differentiator here is really that the RSSI is usually, you see it in acute stroke, so in a patient with symptoms, with a focal neurological deficit, while these incidental DWI positive lesions are mostly covert. And we will hear more about covert brain infarcts or lesions in the next presentation. But is this really the only difference? Is it maybe the same lesion, just in different regions, with the infarct in primary tracts and then with the incidental lesion outside of primary tracts? We don't know yet. And that was actually the main reason for using two different terms, so not calling those also subcortical infarcts. And as I said, quantitative methods, quantitative imaging markers are now also included in STRIVE. So just briefly, we cover here diffusion MRI, susceptibility imaging, and then on the more vessel side and functional side, perfusion and flow imaging, as well as blood-brain barrier imaging. And I won't go into detail here, but we certainly also provide recommendations for MRI acquisition. And without looking at this detailed table, so there are 3 protocols. One is a minimum essential protocol that you should be able to do anywhere where you have an MRI scanner, so also 1.5 Tesla or even low field strength. Then an extended protocol that has a little bit higher requirements, maybe a 3 Tesla scanner then would be good. And a research protocol that not only needs better hardware, but also some expertise at the site to actually perform this. And in the analysis section, again, without going into the detailed table, we cover the following topics, and that's certainly, again, lesions and how to best practice, how to analyze these lesions, also the quantitative techniques, the efforts that are ongoing to technically validate all these markers that we have, and certainly also some deep learning techniques that are now considered state-of-the-art for the segmentation of these lesions, and also going into applications. So how are these markers, lesions already used in clinical trials and have been used in clinical trials already? So that is the main paper, and I put a QR code in the corner if you want to follow that. And I would like to again really thank the entire STRIVE2 group, everybody who participated and who made this possible. And thank you for your attention.
Thank you very much, Marco, and thank you for keeping to time. We've got time for a couple of questions. Please come to the microphone. Philip Bath.
Marco, thank you very much. I wonder when you get a specialist group who have internal conflict about a decision, whether it's time to go out to the wider population. I have to say I don't get turned on by RSSI. I think a DWI positive lacunar infarction says a lot. Most people would understand what you mean. Is it not time? That particular discrepancy for me is the one that's really important. I just can't really see myself using that term. I'd much rather use the word lacunar infarct, because I think most of us know what it means.
Yeah, I think many of us have a concept of what lacunar infarct means, but I'm not sure we have the same concept. I mean, as shown by the now more than 10-year-old survey that the group of Jana Wardlow did, it was certainly a major point of discussion. There's no question around that. And I fully agree. I mean, additional external input. We had 4 external advisors that we added later in the process, but maybe giving it to a broader audience, not only small vessel disease clinicians, maybe would be a good approach. I agree.
Some kind of Delphi process.
Yes,
anyway.
Agreed.
Yes, next.
A great presentation. And I have a question about, in terms of the natural history. So both the RSSI and the diffusion-weighted positive subcortical infarcts technically should not be subcortical infarct, but they all represent the same or similar spectrum. So in terms of 2 different terminology, are they denoting 2 different natural history, or what do we really understand that this lacunar is different, or RSA is different from that diffusion positive, which is in the patient who is having either non-focal symptoms or not having clear focal symptomatology?
Yeah, I think the honest answer is we don't know yet. There's some data suggesting that there is a difference in the follow-up, in the fate of these lesions. So most DWI positive lesions incidental, most of them really disappear on follow-up scans and you don't see anything. And I think most of the recent small subcortical infarcts that we see turn into some lesion of follow-up, mostly with cavitation, but also small cavitation. So I showed you this variable spectrum of fates of these lesions. So I think there is a difference, and more research is needed to build up our understanding and to see if we can merge these 2 terms into one entity.
Just a follow-up question. In your practice, how would you treat it? Would you treat differently the 2 lesions, or would you manage along the similar? Like, would you prescribe aspirin, or?
Yeah, that is a very good question, also highly debated question. And I think if you follow the guidelines, you would treat stroke, so the clinical presentation, and not imaging findings.
Okay, well, maybe we should move on. And these are all really important points that hopefully we can pick up during the panel discussion. I'll just reassure people that there was a huge amount of debate during the development of the STRIVE-2. And under normal circumstances, we wouldn't necessarily have proceeded to a vote, but really that was the only way of resolving it at the time. But, you know, these are incremental steps, so there's plenty of room for further development. Anyway, moving on, it's my great pleasure to introduce the next speaker, who is Mike Sharma. Mike is Director of the Stroke Program at McMaster University and Hamilton Health Sciences, and is the Michael C. de Groot Chair in Stroke Prevention at McMaster University in Hamilton, Ontario. Very pertinent. Mike is going to talk to us about the clinical implications and management of covert brain infarcts, particularly, I think, focusing on randomized trials. Thank you.
Thanks very much, Joanna, and good morning to everyone. Welcome to Canada. I'm going to talk to you about some trials that we've done over the last 10 years, and I must say that the STRIVE criteria really facilitated our work, particularly with regulators who want well-accepted, well-defined outcome definitions. These are my disclosures. Some of the trials that I will be talking about and sub-studies of trials were funded by Bayer, BMS, and Janssen. Now, one other confession that I have is I'm not an expert in small vessel disease. I'm a clinical trialist. One of the things we did in all of this work was we defined the outcomes topographically. We did not make presumptions as to the underlying etiology. And I think that has some implications on how we interpret our findings. So one of the things I would encourage everyone to do is use the term covert rather than silent. So covert implies stealthy and of nefarious purpose. So there is a bad outcome there. Now, why did we start looking at these lesions as an outcome? We postulated that they were the pathologic substrate which led to all of the bad outcomes that we associate with covert cerebrovascular disease, cognitive, motor, and psychosocial, as is increasingly recognized. So this is where we started over 10 years ago in thinking about these and in looking at them in various trials. One of the things that has been alluded to, which did complicate our work, is what happens to these infarcts. Now, this is a study done by the Rotterdam Group, and there are similar studies in the literature talking about the eventual outcome of these lesions. What they looked at, these were patients who were well, participants, I should say, not patients, who were well, who had their brain scanned. Less than 2% of them had diffusion-weighted lesions. And as they followed them out, what they appreciated was a minority, in fact, a small minority, 18%, resulted in cavitation. And an equal number disappeared, so that on follow-up scanning 4 years later, there was nothing to be seen. And the majority were left with nonspecific white matter hyperintensity lesions. Other studies similarly have shown a minority of these lesions cavitate, and studies done here in Toronto have demonstrated that these infarcts occur preferentially at the edges of white matter hyperintensities. So infarction is one of the pathways which leads to white matter hyperintensity, and it was one of the reasons we were interested in this. I'm going to start first with this trial, which is, I think, well known to everyone, not one of our trials, which was a SPRINT trial, which examined intensive versus standard blood pressure control for vascular outcomes. Now, within the trial, there was a sub-study looking at cognitive outcomes, and within that sub-study, there was a smaller sub-study looking at MRI. Patients were over the age of 50, and they had vascular risk factors. An example of one is a Framingham 10-year risk of 15% or higher of a vascular event, or they were older than 75. People who had previous clinical stroke, so symptomatic stroke or dementia, were excluded. The patients were randomized to blood pressure targets of less than 120 systolic or less than 140, the standard arm. And MRI was done at baseline and 48 months. The number of patients in this study was 462. These are the outcomes, and I'll just go through explaining the three that are there. First is white matter hyperintensity volume, which was transformed with an asymmetric sine hyperbolic function. If you wonder why that, you'll have to ask someone else. I didn't quite follow the methods, but it was to standardize the distribution. Second is white matter volume, the annualized change, and the third is total brain volume. What you see is that the change in white matter hyperintensity volume was less in the intensive treated group than it was in the standard treatment group. Recall from Sprint Mind that there was a difference, a reduction in the number that developed MCI in the intensive treatment group. Total brain volume, however, was also smaller in those who were intensively treated. The difference was small, but the implications are unclear clinically. Does this mean that it was an adverse effect or possibly conflated by the use of diuretics and subsequent dehydration in patients who were in the intensive arm? A colleague of mine, Aristides Katsanos, has completed a systematic review and meta-analysis of trials which examined statins for the outcome of covert infarcts. So again, this is a surrogate radiologic outcome, and we feel pathologically associated with important clinical outcomes. 3 trials were included, and you'll see that these trials, apart from one, use low dose, older statins, pravastatin and simvastatin, and the one trial which did use a modern statin, rosuvastatin, was at a very low dose. Now, when meta-analyzed, these trials did suggest a treatment effect for the outcome of incident covert infarcts in these patients with a risk ratio of 0.63. To my mind, a suspiciously strong treatment effect given the lack of data elsewhere. However, this is interesting and we will need to follow up with it with analysis of larger data sets with more intensive statin therapy. I'm going to move on to the trials that we have completed, which examine antithrombotics. Now, most of these are sub-studies embedded in large trials. One of the large trials, to give you an idea of the sort of work we've been doing, is the COMPASS trial. Now, this randomized 27,395 individuals with atherosclerotic disease, which was stable, so not linked to an index event, to one of 3 arms: aspirin by itself, rivaroxaban 5 milligrams BID alone, and a combination of rivaroxaban 2.5 milligrams BID and aspirin. The trial was stopped early after a follow-up of 1.9 years by the DSMB for overwhelming efficacy of the combination arm when compared to aspirin. By the way, when the trial was stopped, the rivaroxaban arm also showed an effect for stroke in particular. However, once adjudication was completed and the number of hemorrhagic lesions were counted, this no longer was significant. Now, within the COMPASS trial, within the composite outcome, we saw an almost 50% reduction in the occurrence of incident stroke, which was really quite intriguing for us. The MRI sub-study involved doing an MRI at baseline along with blood for genetic markers and biomarkers, and then an MRI at study end. We'd planned on about a 3 to 4 year duration. However, the study had ended less than 2 years. One of the things for anyone who is doing this sort of trial is to know that when a study ends precipitously, it's very hard to collect MRIs because all of the patients have to be closed out very quickly, and you need to get these scans done. At the end, we were left with 1,445 paired scans in our participants. These are the outcomes that we looked at, and you'll note that the confidence intervals all cross the null. In particular, the outcome of covert infarction, we saw no treatment effect in spite of a robust effect for clinical stroke. We combined it and looked at it with other measures, including incident covert infarcts with stroke, with ischemic stroke, and you see a trend favoring the combination therapy. However, nothing significant in this trial at all. One of the things we did see, and this has been seen in every cohort we studied, is the covert infarcts were much more common than clinical symptomatic stroke. This is of importance in terms of how we design trials, and I'll show you a design of 2 trials which incorporated this. In this population with atherosclerosis, the covert infarcts were 7 times more common than clinical stroke. In spite of that, overall, we had a low incidence of covert infarcts, 3.3% over almost 2 years in this population. We had expected more. Now, Navigate ESIS was a trial that was running at the same time as COMPASS, testing rivaroxaban compared to aspirin in patients with embolic strokes of uncertain source. We embedded an MRI study within this, and we thought we had a good chance of seeing an effect because this trial, in terms of patient selection, picked patients who were preferentially likely to have an embolic etiology, which we thought was amenable to anticoagulation. It turned out not to be the case. The findings from this, I think, were interesting, however. The incident brain infarcts, again, were predominantly covert infarcts. So 4% were clinical stroke out of 12% rate of infarction overall. Microbleeds occurred, and again, this was just about over 1 year of follow-up in about 7% of patients, and were unaffected by the treatment assignment. So same likelihood of having microbleeds on aspirin as on rivaroxaban. This has been a consistent finding in our trials. Antithrombotics do not influence the accrual of cerebral microbleeds. Efficacy, as with the main trial, was not there, so no treatment effect for covert infarcts, infarcts overall, or cerebral microbleeds. Now, we moved to look at a different class of compounds. These are the factor XI inhibitors, and for a number of reasons, we expect them to be both effective in stroke prevention and safer than our current generation of anticoagulants. In these trials, two that I'll tell you about, Axiomatic and Pacific, we combined them with antiplatelet agents to mimic the dual pathway approach taken in COMPASS. Axiomatic was a short-term trial, so patients were recruited, randomized, and then the study finished within 90 days. The endpoint was a combination of clinical stroke and MRI-defined covert infarct. So in this population, we had MRIs at baseline and at 90 days in all participants. We ended up at the end of the trial with 2,139 paired MRIs. There are various doses of milvexian, the factor XI inhibitor, compared with placebo. All of the patients in this trial had to have atherosclerosis in a feeding vessel, not necessarily stenotic, not necessarily severe, but present. We excluded those with cardioembolic sources such as atrial fibrillation, which needed treatment. The importance of including MRI endpoints and the importance of the definitions in STRIVE were that regulators had to accept this combined endpoint as valid. And both the definitions in STRIVE, what we've seen in COMPASS, convinced regulators. Now, we don't often think of regulators as important in the scientific enterprise. However, they are. Where there's regulatory approval, there follows funding and activity. This is the outcome of symptomatic ischemic stroke, placebo on the left-hand side of the slide, and ascending doses. All doses of milvexian were associated with a reduction in symptomatic stroke of about 30%, with the exception of the highest dose. Now that we've looked at carefully appears to be a chance finding. However, this reduction for all the other doses is really very nice. So we had an impact with milvexian, which was dose-dependent on symptomatic stroke. We, however, had no impact at all on covert infarcts. So covert infarcts were about the same across the dose range, no sign of a dose effect. So again, we see this discordance, just like we saw in COMPASS, with an effect on clinical stroke and no effect at all on these covert infarcts. We dissected them out looking at lacunar infarcts. Now, when we use the term lacunar, just to echo what Marco During implied in his talk, we're speaking topographically, not by etiology. So what we mean are small subcortical infarcts in locations we traditionally would consider lacunar. We separated out lacunar and non-lacunar infarcts, thinking we might see an impact in non-lacunar infarcts, which were more likely to be embolic. However, we did not. Pacific stroke, very similar, a different agent, asundexian, once again a factor XI inhibitor compared to placebo, 3 ascending doses. Now here, the MRIs were done 6 months apart. Because of what we know about the natural history of these lesions, we might have expected a different outcome here. More of them might have disappeared or not cavitated. At 90 days, we saw just about all of them. By the way, surprisingly, at 90 days in axiomatic, the majority of infarcts that we saw were diffusion restricting, suggesting that they were still ongoing by the time that the 90-day outcome had been determined. Here at 6 months, we looked at the MRI. The trial continued for 12 months. And once again, we saw no effect on covert infarcts. In Pacific, just like in axiomatic, there was an impact on clinical stroke and on clinical stroke in TIA, but nothing on covert infarcts. So covert infarcts in various populations that we studied are far more common than clinical stroke. We have not seen an impact of antithrombotics in any of our trials at all, and I think they're ineffective, and there may be reasons for that we can speculate on. There certainly seems to be an effect of blood pressure lowering in MRI measures in small patients, a small number of patients that does need to be replicated, and it correlates with what was seen clinically. Potentially statins, though, I think that those findings are a little more frail given the nature of the underlying trials. One trial I didn't go over is PFO closure. That trial looked as well at covert infarcts, and so no effect there. Now, this is, I think, still a valid surrogate outcome. One of the things that we need to do is correlate how much of the surrogate outcome is linked to a clinical effect. What we really care about is function and cognitive function, how many covert infarcts, what volume of white matter hyperintensity increase is related to a measurable deterioration there. And that work will take some time. Thank you for your attention.
Thank you very much indeed, Mike. That was super. I mean, going forward and just thinking about the question around, potential differential mechanisms in large artery, small vessel, etc., where would you see this going?
So, I mean, it's a great question. So one of the possibilities is that the mechanism for these small infarcts involves small vessel disease and is not amenable to antithrombotics, is inflammatory or hemodynamic or something else, some combination thereof. I think the next step is we're going to pool the data, look at whether there's an impact on larger topographically embolic appearing infarcts, which would really solidify that we need a different approach. I think from all of this work, what we need to do next is look at other mechanisms for these infarcts. Inflammatory mechanisms seem to be quite attractive at the moment, and that should be the next series of trials.
And if I could just ask another question. In any of the trials where you've been tracking the presence of the covert lesions in the MRI subgroup, have you had other sub-studies where you've gone back and tried to reevaluate the patients to see if there was some potential embolic source that was missed, or, as the technologies have advanced over the years with more sensitive detection of AF and things like that? Have you tried anything like that? Do you think we're missing things, or?
Yeah. So one advantage for us are that these trials were either embedded in large vascular trials where we have very good tracking of that. And we haven't seen an excess of embolic sources identified. In COMPASS, 4% was the rate of detection of atrial fibrillation. Likewise, in axiomatic and the other trials, selection criteria mostly excluded them. Now, in axiomatic, the embolic source was almost certainly vascular. We chose the patient population that way.
Okay. Yes, Chris.
Good morning.
Good morning.
Good morning. Mike, could you comment on the finding that there was no effect of these antithrombotics on microbleeds?
Yeah, so I think we were surprised by that, but it's been consistent across all trials. It just suggests that the mechanism microbleeds does not involve hemostasis. So what we have to remember is antithrombotics don't cause bleeding. There's no reason for normal blood in a normal vessel to bleed. They really impair hemostasis. So what's happening with microbleeds is a process that does not involve hemostasis.
Sorry, last time I didn't introduce myself. Ravinder, I'm one of the neurologists. The question I have is maybe the effect what we are seeing here with the blood pressure and the statin are reflecting the histopathology, which we see the lipo and the hyalinosis piece. And the hyalinosis is driven by the pressure and some deposition of the cholesterol. So maybe the effect what we are seeing is reflective of the predominant pathology, which is operational in terms of mediating the effect of small vessel disease. Maybe it's not dependent on the microthrombosis, which we are targeting with the antithrombotic. So do you think that could be one of the mechanisms that we are seeing some signal in terms of the blood pressure and the statin, not with the antithrombotic so far?
Yeah, look, I think that's a very good point, and that really is what we're saying here, is that that mechanism for these lesions is not driven by thrombosis. Where we thought we might see an effect is in the short-term trials where outcomes were determined at 90 days right after a symptomatic stroke. So there you would think thrombotic mechanisms are operative. We still didn't see an effect.
Last question.
Ken Uchino from Cleveland. If many of the trials show that MRI outcome was not significant, you state that MRI remains surrogate outcome, but do you think that's, if you see the clinical endpoints reduced but not the MRI, does it mean that it's potentially diluting the effect if you put it at combined outcome?
So Ken, I think that's one possible conclusion. The data that's at variance with that is what you see in Sprint Mind and also in the statin trials, where there was an impact there. One of the statin trials, by the way, also had an impact on cognitive measures, as did Sprint Mind. So I think for that reason, we have to be careful in concluding that there's no validity to it. And really, what our data says is antithrombotics don't seem to be the answer for this.
Thank you.
Yeah, thank you very much for the great discussion. I just want to remind our online participants, we have 50 people online, that you can put questions also in the chat. And then it is my pleasure to introduce the next speaker, which is Joanna Wardlow, my co-chair, Professor of Applied Neuroimaging at the University of Edinburgh in Scotland and the Foundation Chair in the UK Dementia Research Institute. And she will speak about cilostazole and isosobite mononitrate.
Well, thank you very much for the introduction. These are my disclosures. I have no industry conflicts. So small vessel disease, we've heard already quite a lot about. And while it's possible that an embolus or a small atheromatous plaque, either on the parent artery or actually in a perforating arteriole, can cause a small subcortical infarct or acute lacunar infarct, whatever people prefer at this point. In fact, when you track embolic sources and large artery sources, in general across a large number of studies now, those are relatively infrequent. And the commonest cause by far is this intrinsic small vessel disease, which has been variously described as lipohyalininosis or fibrinoid necrosis. And doesn't, although it's sort of often considered as a small vessel type of atheroma, really there's not much evidence of that. And I guess the other thing is to think about the underlying vascular dysfunctions that are seen in small vessel disease, and that includes that there's a decrease in vasoreactivity. The blood vessels don't react so well. They can't increase blood supply and oxygen, nutrients when the brain is active. There are areas where the blood-brain barrier becomes subtly leaky, particularly as it now seems around the edges of new forming lesions, and there's an increase in general vascular stiffness, which means the vessels are not pulsating nice and smoothly. And this seems to be a combination of factors which captures the dysfunction that's seen in small vessel disease. And then if you look at it at the endothelial level, so at the lining of the small vessels, there's evidence from both human studies and a range of preclinical models that the cells are deficient in nitric oxide, which is a really important vasoregulator, particularly vasodilator, either because there's not enough being made or it's being broken down too quickly. The tight junctions that hold the endothelial cells together are not as effective as they should be, which in part accounts for some of the leakiness. When endothelial cells become dysfunctional, they actually interfere with other cells in the brain, so they block the oligodendrocytes, which form myelin, so they affect myelination that way as well. And then there is evidence of inflammation, which is not yet well understood, but it's definitely there, and it seems to be a bad thing. And then you also have problems with astrocytes, which are really critical for passing energy to neurons. So a whole bunch of things are just not working very well as a consequence of the endothelial dysfunction. And we've heard a lot already this morning about atheroma and approaches geared at trying to manage platelet function and, blood pressure as well, traditional stroke prevention mechanisms. And this is just an example from a study where we've been tracking patients who presented to our hospital with either a small subcortical infarct or a small cortical infarct, and they act as a control group because they're given the same secondary prevention measures. And all I can say is that there's about 20% rate of people in this study with small subcortical infarcts at presentation who go on to develop new DWI positive lesions. And we would not have picked these up had these patients not been going into the scanner at regular intervals as part of the study. And it's consistently about 20% get a new DWI positive lesion. The vast majority of these lesions were not associated with conventional stroke symptoms, and they wouldn't have come to light if the patient hadn't been in the scanner. And many, when you track them and you interrogate the relatives in detail and you ask the patient systematically about their symptoms, they do seem to be related to neuropsychiatric and relative reported cognitive symptoms. So they're not silent, they are simply covert. And as Marco said earlier, they are typically not in the primary motor and sensory tracts. And I think if you get a tiny lesion somewhere else in your brain, you're very likely not to notice it in the same way that you'd notice something in your primary motor and sensory tracts. And the other problem with this is that although many of these may disappear without leaving much of a trace, or they may turn into a small white matter hyperintensity long term, actually they can go on to cavitate, and when they do, that's associated with worse long-term outcomes. And they can also develop secondary damage, so these so-called caps and tracts, which are like Wallerian degeneration, indicating axonal dieback. And this is also associated with worse outcomes. So the bottom line is that if you get more damage, you end up with more damage, and the more damage you have in your brain, the more vulnerable it is to further damage. So trying to stop these things from happening is actually really important. And because these patients have all come through a stroke clinic, they're already on optimal secondary stroke prevention, and yet they're getting these recurrent lesions despite that. And this is observational, it's not a randomized trial, but it's actually quite scary. I mean, I almost dread opening the next scan in one of these patients and thinking, what am I going to find this time? And every time this happens, we go back and we look, and what have we missed? And do they need more, ambulatory monitoring or whatever? And we're not finding good reasons for any of these things. So it just underlines that this is not really an atherothromboembolic condition as we think about it. Stroke is the tip of the iceberg. It just underscores that small vessel disease is not really atherothromboembolic, and having these lesions worsens outcomes. Traditionally, the risk factors for small vessel disease have included many of these vascular risk factors, which we've heard about, as well as a number of other lifestyle-related factors. And again, just emphasizing this, we did the ESO guideline on covert cerebral small vessel disease, and we've just submitted the guideline for lacunar stroke small vessel disease, finding a broadly similar picture, that antiplatelet drugs should be avoided in covert small vessel disease unless there's another good reason for giving them, such as ischemic heart disease, and so on. The antihypertensives may be beneficial, despite with good blood pressure control, but even with good blood pressure control, patients can still progress, and so on and so forth. And so really it sort of points to the fact that there's a lot of other things going on that we're not really getting at. And this comes from a systematic review, which I did several years ago with Philip Bath, and basically we looked at a number of drugs that were already in existence which had evidence of one of a number of different functions that we thought were potentially important in the mechanism of small vessel disease, such as blood-brain barrier dysfunction or other endothelial cell effects, etc. And effectively, looking at what was already available was perhaps licensed for other indications, and picking out the ones that seemed to affect the majority or as many of these possible mechanisms on the basis that if they could ameliorate more of these mechanisms, then they might be more effective. And on the basis of that, we initiated the lacunar intervention trials, and we decided to assess 2 drugs. Effectively, there were a number of drugs that we could have picked, but the 2 that seemed to have the most evidence from use in either other vascular indications or already had a large evidence base from other randomized trials were cilostazol and isosorbide mononitrate. Both these 2 drugs have complementary effects. They both act on the endothelium. Cilostazol helps to sustain the presence of nitric oxide effectively, and improves endothelial function. And there's some evidence that it may also help improve oligodendrocyte function in preclinical studies. There are trials in excess of now about 12,000 patients, mainly from the Asia-Pacific countries, showing that it reduces recurrent stroke without increasing the risk of hemorrhage, and some minimal evidence in sub-analysis that it might help, particularly in lacunar stroke, and more benefit in long-term use. But that remains to be shown, and very little evidence in Western populations. Isosorbide mononitrate is widely used in the UK for management of chronic angina. It's a nitric oxide donor. It improves endothelial function. And despite being used for decades in ischemic heart disease, there is no good evidence at all of any effect in the brain. So we initially did the LACI-1 trial, and this was published in 2019, and I won't dwell on it excessively, but really the purpose of this was simply to try and establish a protocol to see whether we would be able to recruit patients. We just had 2 centers. Would they be able to take either of these 2 drugs or both drugs together, because we wanted this to be a factorial design, for up to 8 weeks? Did they get symptoms? Were they tolerable symptoms? Did they get any adverse effects? And we also did some both blood marker measurements of platelet function. We looked at things like vascular stiffness, and we also measured cerebrovascular reactivity. And yes, there were some symptoms, but mostly they were well tolerated. They settled down. If you ramped the drugs up slowly, there was evidence that in patients who received either drug or both drugs, they had improvements in cerebrovascular reactivity. And remember, this is just very short term. And there were no safety concerns. So on that basis, we took the next step, which is to do the LACI-2 trial, which was really to assess the feasibility of testing these 2 drugs in the longer term. Because if this is a chronic disease, if you're going to manage it, you've got to be able to treat it in the long term. And that means that patients have to be able to stick to the drugs, that they have to tolerate the drugs over at least a year, and that this is safe and it's not going to worsen outcomes. And we also wanted to collect more information that we could then use to power a larger phase 3 trial. And the main results were published earlier this year. I think this is where it's important to know your disease, because one of the problems with small vessel disease and lacunar stroke in particular is that the recurrent stroke rate is quite low, and they have relatively low dependency, and death and major adverse cardiovascular events are very rare. So you can't power a trial on those individually. The thing that is most prevalent is any cognitive decline or dementia, and there are other outcomes, but the data on the frequency of those is very poor. We did consider looking at intermediary outcomes such as on MRI, but they don't replace clinical outcomes. They're of less importance to patients. They're really difficult to do on a large scale, and there's still problems with things like standardization, particularly if you're trying to collect the MRI in routine NHS hospitals. So we decided against having an MRI outcome and focused on clinical outcomes. I won't dwell on this, but basically we collected patients, we recruited patients who had a clinically evident lacunar clinical syndrome, and supportive imaging. They didn't have to have MRI if it wasn't available. They could have a CT scan so long as it was didn't show another cause of their symptoms. Patients were randomized to either cilostazol or isosorbide mononitrate or both versus neither. And all patients received guideline stroke prevention. So this is on top of guideline stroke prevention. You can see the outcomes here, and all analyses were intention to treat, and we adjusted for main predictors. One thing we did do was look at ways of trying to maximize the power of the cognitive assessments, because traditionally cognition is very difficult to assess after stroke. You know, patients with stroke typically have problems completing some of the tests because, you know, they have problems with motor function or the visual field loss or whatever it might be. And we wanted to try and make use of as much data as we could from multiple different sources. So this is a 7-level, or it could be a 4-level cognitive scale, which is based on the Diagnostic and Statistical Manual of Mental Disorders criteria for cognitive, neurocognitive disorders. This is the 7-level score here, and it maps to what are relevant practical levels of disability for patients. So it's also highly clinically relevant. And of course, once you've got an ordinal scale, it means you can use ordinal statistics, and they are very powerful compared with dichotomous results. So this trial was hit by COVID, you know, just about every problem that you can get in clinical trials. But anyway, we had 363 patients recruited at 26 UK sites, and we met our feasibility, retention, tolerability, and safety targets. There were no concerns there. These are the baseline characteristics, and just very briefly, they were very typical of patients with lacunar stroke, typically slightly younger than the average for other types of stroke, more males than females, very low levels of MRS dependency at recruitment, low NIHSS scores, and you can see other information there. And the vast majority had a visible index infarct despite our quite lax approach to inclusion criteria. This shows you a composite outcome which included recurrent stroke, MI, cognitive impairment, dependency, and death. And each drug individually, so this is isosorbide versus no isosorbide, cilostazol versus no cilostazol, and both versus neither. Neither of the drugs individually reduced the composite, but when you put both drugs together, you can see that there's a significant effect. The other point to note is that isosorbide mononitrate reduced recurrent stroke, and cilostazol reduced dependency. So some evidence that there might be some complementary effects of these two drugs, although it has to be remembered that efficacy was not the major purpose of this trial. And it does also make the point that cognitive impairment is the single biggest major outcome in this population. I took the slide out, but when we also looked at covert infarcts on imaging, in addition to clinically evident recurrent strokes, we saw the same overall pattern. So far more covert lesions than, or infarcts on imaging over the course of the year than clinically evident, and the same overall pattern in terms of reduction with isosorbide mononitrate. Anyway, this shows you the dependency results, the stacked bar charts, and this is a dichotomous modified Rankin scale, and this is an ordinal shift analysis. And again, individually, on the ordinal shift analysis, neither drug conventionally reached significance, but the two together reduced dependency, and overall similar results for the dichotomous dependency versus no dependency outcome. Cognition, isosorbide mononitrate reduced this 7-level ordinal cognitive scale, so better cognitive outcomes with isosorbide mononitrate, and that effect was preserved when both drugs were put together, and in fact possibly even slightly strengthened. This shows you the MOCA scores. If you just use the MOCA score, you'd see the same general overall pattern, but you would find you know, the power of the individual MOCA score is not so good. We also looked at a number of other outcomes. This is mood and quality of life, and isosorbide mononitrate improved quality of life. Cilostazol did not conventionally improve quality of life, and the combination of both drugs did improve quality of life. So we've got this sort of overall pattern, which is really interesting. There were some strengths. The baseline data were well balanced. They were typical patients. We showed that this approach is feasible. They didn't stop taking the tablets because of adverse symptoms. This was not intended to be an efficacy trial, and it was open label, and there were a number of missing outcomes. You know, not everybody completed all follow-up, but there was no evidence of any bias by drug allocation. And it's possible that a year of treatment may not be long enough to see the effects of cilostazol. This is a really chronic disease, and of course badly disrupted by COVID. But nonetheless, the general message seems to be that there are some benefits with isosorbide, potentially reducing recurrent stroke, improving cognitive impairment and quality of life, cilostazol reducing dependency, and both drugs sustaining the effects of each other with the exception of recurrent stroke. Why might this happen, and why might they be complementing each other? So I won't go into this in detail, but basically if you've got one drug which is trying to improve nitric oxide levels, improving mitochondrial efficiency, another drug which is stopping the breakdown and helping to unblock oligodendrocyte precursor cell maturation block, then you may not only be preventing the primary damage, but you may also be able to help some of the secondary damage. So, drugs which improve endothelial function may help improve outcomes in small vessel stroke. It supports the idea that there's an endothelial intrinsic non-atheromatous pathology, and it might be that patients with other presentations of small vessel disease might also benefit, so cognitive presentations or covert small vessel disease. There's a wide range of other repurposed drugs available, and I would really encourage the development of more trials to adopt a similar approach and try and test more endothelially active drugs. So thank you very much.
Thanks a lot, Joanna. It's a fantastic achievement with a lucky trial. We have time for one immediate question.
It's a small trial. It may all be a fluke. It's going to be practical.
We surely hope that not. If there's no immediate question, for the sake of time, then we will keep those for the Q&A that we will have after the last presentation. And I'd like to introduce our next speaker, Eric Smith, who is a professor of neurology, radiology, and community health sciences at the University of Calgary, and will today talk about small vessel disease across the lifespan.
Thank you, Marco. It's a pleasure to be here this morning with you. So my topic is the emergence and effects of cerebral small vessel disease across the lifespan. Maybe I'll use the computer mouse here. There we go. These are my disclosures, none of which are relevant to the topic of this presentation. This is a topic on which I have not published that much previously, so I was greatly aided in this presentation by the very recent publication online of this review by Ellen Backhouse, James Boardman, and Joanna Wardlaw on the early life antecedents of cerebral small vessel disease, published in Hypertension a couple of weeks ago. So most of what I'm going to discuss will be in this, comes from this review paper. And I invite you to read this paper in detail. It's got many more details and interesting information, and I'll summarize some of the findings from it. So as we know, cerebral small vessel disease is a phenomenon that's been well described in people in later life. And we know that the elderly are at risk for signs of small vessel disease, including lacunes and brain infarcts, white matter hyperintensities, microbleeds, perivascular spaces. And these have been well linked with, when identified in later life, with important increases in risk for stroke, dementia, and mortality, according to data which was taken from this systematic review by Stephanie DeBette. What I'm going to discuss in this presentation is when during the lifespan early signs of small vessel disease begin to emerge, as well as to discuss a life course approach to the epidemiology of small vessel disease, focusing on determinants in early life, including in childhood, infancy, in utero, and even maternal impacts and effects. So we know that small vessel disease is an important phenomenon seen radiologically in the elderly In the upper right panel are data from the Pure Mind study, of which I'm the PI. It's a sub-study embedded within the prospective urban-rural epidemiological study led by Salim Youssef. And we can see, even in people in the 40s, we begin to see a few percent of people can have high white matter hyperintensity, as shown in the orange line, have one or more lacunes or brain infarcts, as shown in the blue line, or have cerebral microbleeds, as shown in the red line. And this rises to about 5% of people in their 50s, and then 5 to 10% of people in their 60s. And by the time people in their 70s, you see, especially with white matter hyperintensity burden, an accelerating increase over the lifespan, such that in the 70s, up to a quarter of people can have high white matter hyperintensity. However, there are many fewer data from people less than 40, but we are beginning to see that there are early signs of physiological changes. For example, we see increased white matter diffusivity with higher blood pressures, a finding that I'll expand on in the next slide. We can see in people in their 30s and 40s, already they're beginning to see physiological changes in aortic stiffness in people with hypertension and other vascular risk factors. And we see that people with vascular risk factors have low brain volumes, even when the brain volumes are measured in their 30s and 40s. So we're beginning to extend this window where we can detect early effects on the brain into the 30s and 40s, whereas previous studies had focused more on the 50s, 60s, and 70s. So, pardon me. So, for example, this study from the Framingham cohort looked at MRI scans in one of the offspring of the cohorts with a mean age of 39 and range from 19 to 63 years old. So this is focused on a lot of people in their 30s and 40s. Few of them had a clinical diagnosis of hypertension. Only 7% were on hypertension treatment. The overall white matter hyperintensity volumes were quite low, as you'd expect in a population with mean age less than 40, 1.7 cubic centimeters. An amount of 10 cubic centimeters or more might be what you would consider clinically significant or possibly related to cognitive impairment decline. So these are very, very small volumes. What you can see in the right panel and panel B is maps of mean diffusivity seen on diffusion MRI. So higher mean diffusivity means that water protons are free to diffuse more freely, and this generally indicates either an increased permeability of the vasculature or possibly loss of cellular elements like myelin. And even in this young population, the color-coded areas around the ventricles are regions where higher blood pressure was associated with higher diffusivity. The panel in the bottom left here shows one specific region in the anterior corpus callosum with a scatter plot. On the y-axis is mean diffusivity. On the x-axis, not labeled here, but these are blood pressures increasing in size from the left to the right side of the graph. The blue dots are participants that were normotensive. The red dots were participants with prehypertension. The green dots are participants with hypertension. So you can see that mostly this is a population that's either normotensive or prehypertensive, but yet you can see there's a very clear linear relationship between higher blood pressures and higher mean diffusivity, as shown in the box plot in the middle, where the three box plots from left to right are the participants with normotension, prehypertension, and then hypertension. As you can see, as you move across each stage, you see higher mean diffusivity. So even in people in their 30s and 40s, at the very early stages of developing prehypertension, we can already begin to see quantitative effects on diffusivity within the brain. So if small vessel disease, emerges, the signs in the brain are beginning to emerge at an earlier life stage than we've typically thought of. But other studies are taking that back even farther to look at the early life risk factors for later life small vessel disease using a life course approach, which is an important concept in epidemiology as defined by Ben Shlomo. It's the study of long-term effects on chronic disease risk of physical and social exposures during gestation, childhood, adolescence, young adulthood, and later life. And the British epidemiologist Barker was one of the proponents and like early developers of this idea. Barker noticed that regions in England that had the highest infant mortality also had the highest later life cardiovascular mortality. And Barker hypothesized that there was some metabolic reprogramming in infancy that conferred this later life risk. And as we've now discovered, there are potentially plausible biological mechanisms by which this hypothesis might be true, and we'll come back to that later. So a life course approach means that we're moving from a later life focus on risk factors like hypertension and outcomes like Lacunes, with a focus on secondary prevention, to understanding the risk factors for the risk factors, including lifestyle and behavior, but also going all the way back to child health and development, and even maternal health and health in infancy. And so now we're thinking about primary prevention, preventing small vessel disease, but also thinking about primordial prevention, preventing the risk factors for small vessel disease. So I'll go through some of the research that's been done so far on childhood and early life factors. So one factor, of course, is education. That's measured in most studies of small vessel disease because it's an important determinant of cognitive outcomes, as we know. And in this table, there's a green plus when there's evidence of an association. It doesn't necessarily mean it's a positive association. I just mean that the two have been linked with statistical significance. And where there's a minus, it's where studies have so far been neutral or not shown an effect. So studies have linked higher childhood education with less risk of later life white matter hyperintensity. Most of the individual studies are neutral, probably because the effect is fairly small. But in this review, systematic review by Ellen Backhouse and colleagues published in Neurology, when you pool across all the studies, you see an effect does emerge. Not a medium strong effect with odds ratio 1.24 for lower childhood education being associated with higher later life white matter intensity burden. Studies looking at Lacunes or brain infarcts have so far been neutral. One study suggested an association between low early life childhood education and later life risk for cerebral microbleeds. Studies on perivascular spaces and CSVD scores, only one study but found neutral results. And there's one study that linked low childhood education with higher risk for cerebral small vessel disease summary score on neuropathology in an autopsy-based study. For low childhood IQ, similar findings. A prior systematic review found that lower IQ was associated with later life higher amount of white matter hypertensities. Pooled correlation coefficient was negative 0.07, so that's a very mild correlation, but it was statistically significant across 6 studies. And another study that pooled data from 4 cohorts found that for each additional point of childhood IQ, you had lower odds of white matter hypertensity, Lacunes, infarcts, and total CSVD score, but not cerebral microbleeds or enlarged perivascular spaces. There have been fewer studies on low childhood socioeconomic status, but one found that low childhood SES was associated with a lower odds of Lacunes, but no association with white matter intensities, infarcts, microbleeds, perivascular spaces, or CSVD score. So this is unusual in that it's the opposite direction that one would have hypothesized, and it may simply be play of chance. Another study found that parental occupation, which was used as a surrogate for childhood SES, was negatively associated with white matter hypertensities. So parental occupations associated with higher SES were associated with lower risk for later life white matter hypertensities with a kind of a mild correlation. One study has looked at the relationship between birth weight and later life cerebral small vessel disease. So in this study, the investigators pooled data from 4 cohorts, Straddle, the Lothian birth cohort, the Dutch famine, and Simpson studies. Each of these studies included assessment of small vessel disease in later life with well-documented records of birth weight, and examine the odds of cerebral small vessel disease lesions for each additional 100 grams of birth weight, adjusting for age, sex, hypertension, smoking, adult SES, and gestational age, so it's low birth weight for age. And generally, higher birth weight is associated with less risk for cardiovascular disease and other outcomes. And as you can see in the table on the right, they found that there was an association between higher birth weight and lower odds of lacunes and infarcts and perivascular spaces, but no difference in the risk of moderate to severe white matter hypertensity or microbleeds, and overall small vessel disease score was not significant. And then a study of placental weight found that low placental birth weight correlated with higher white matter hypertensities in later life, with kind of mild to moderate correlations. There are interesting potential mechanisms that might link maternal health to risk for small vessel disease in later life too. One mechanism is epigenetics, which is defined as the study of changes in gene function that are mitotically or meiotically inheritable, but that do not entail a change in DNA sequence. So this includes DNA methylation, as well as gene regulation by non-coding mRNAs. And we know from studies in the cardiovascular literature that maternal diabetes, hypertension, and smoking have been associated with altered DNA methylation patterns in offspring. But so far, no studies on cerebral small vessel disease. So this is a biological mechanism by which Barker's hypothesis might be true, right? That this is the means by which the DNA regulation can be reprogrammed in relation to early life exposures or even maternal exposures, and that may confer later life risk for conditions such as cerebral small vessel disease. Additional supporting evidence that life course effects may be important for small vessel disease come from literatures showing association between infant and early childhood characteristics and later life incidence of vascular risk factors, which of course are also risk factors for small vessel disease. There's literature suggesting life course risk factors for stroke, which is some stroke is caused by small vessel disease and shares a lot of risk factors. There's also a large literature on life course risk factors for later life cognitive decline and dementia. And I invite you to read that review article by Backhouse and Wardlaw for the details. Of course, late life cognitive decline and dementia is a consequence of small vessel disease. However, to date, there have been few studies that have examined whether small vessel disease is the mediating factor between these maternal infant and childhood exposures and later life cognitive decline. Other pathways could be increased vulnerability to neurodegeneration and Alzheimer's disease, or just lower brain development. So some of the mechanisms that could link early life risk to later life cerebral small vessel disease and its effects could include that these risk factors are increasing risk for developing conditions like diabetes and hypertension. Another factor that could induce vulnerability to the effects of small vessel disease in later life may be an impact on brain reserve or cognitive reserve. Brain reserve being defined as the structural integrity of the brain. More developed, larger brains tend to be more resilient to later life pathologies, such as small vessel disease or Alzheimer's disease, such that for a given level of small vessel disease, one might have preserved cognition, whereas if the brain did not structurally develop properly because of adverse exposures during childhood or infancy, then the brain may be more vulnerable to the effects of small vessel disease. And then cognitive reserve is a similar concept, but related to the functional reserve capacity of the brain. So if the brain reserve is the better hardware, then the cognitive reserve is better software. Potential future research directions in this area. I think we need more studies that quantitatively assess vascular physiology and early brain structural changes in the 30s and 40s to really understand when these processes begin. It looks like cerebral small vessel disease is a process that evolves over multiple decades, and we don't really fully understand where the beginning of this process occurs. We need, of course, more longitudinal studies, but we're not going to have studies that span the entire lifespan. So we need to add retrospective assessments of childhood and young adult exposures to existing later life epidemiological studies. Some of the most powerful studies have been those that have been able to take participants in later life and link to objective evidence like birth records or childhood school records or IQ records, like, for example, the Lothian Birth Court has done. And then we need to analyze pathways from early life exposures to later life cerebral small vessel disease with a focus on the mediating factors, including whether it's small vessel disease or not. And we need to think about including brain imaging for cerebral small vessel disease in studies linking early life exposures to dementia. So in conclusion, vascular risk factor associated structural brain changes may begin to evolve in the people in their 30s and 40s. Low child IQ and perhaps to a lesser extent, low child education and low birth weight have been associated with signs of cerebral small vessel disease in later life. And more studies are needed on the diverse manifestations of cerebral small vessel disease and the factors that mediate associations between early life exposure and later life cerebral small vessel disease and related cognitive decline. So thank you very much for attending this session. This is some of the research group that works with me, and happy to take questions and participate in the panel discussion. Thank you.
Thank you very much, Eric, for an excellent presentation. We can start with an online question. And the question concerns patients in their 40s, where it's sometimes difficult to determine small vessel disease or demyelinating disease as the cause of these lesions. And Yu Wei Chen from Taiwan asks, what do you suggest to follow up those patients?
Yeah, that's an excellent question. Of course, one has to consider monogenic disorders too, which was not the subject of my presentation, but you'd have to consider conditions like CADASIL and carousel. So getting a careful family history, of course, doing an appropriate neurological workup, which is probably outside the scope of my response to the question here, but you might have to consider investigations aimed at excluding, like in Canada, the most common demyelinating disease would be inflammatory demyelinating disease from multiple sclerosis, so you'd have to do an appropriate workup, including contrast-enhanced MRI, potentially CSF analysis and other investigations. But I certainly have a number of patients where I have not diagnosed MS and there is no clear family history. Maybe this is related to the interesting observation from Dr. Wardlaw that despite initiating appropriate secondary prevention, many patients are still progressing. So there's certainly unknown factors too in the progression of small vessel disease and white matter disease that we don't fully understand.
Thank you. Please go ahead.
Philip Bath, Nottingham. Thanks, that was lovely. I'm trying to draw the analogy with atherosclerosis because although it's very clear that small vessel disease is related to endothelial dysfunction, blood-brain barrier, vasoreactivity and so on, that can't be the start of it. The endothelium, the blood vessel is exposed to blood. Now we know in athero that changes like long-term inflammation, hypercholesterolemia, blood pressure through shear stress influences endothelial function, monocyte chemotaxis, smooth muscle cells change phenotype from contractile to proliferative and so on. And they then give the lesion that causes the thrombotic event. The question is, how do you draw this distinction between large and small vessel arteriolar changes? What is different in the blood that is expressing these changes on small vessel endothelium rather than large vessel endothelium? And that for me is the critical problem. And I was just watching a talk trying to think, what do all those factors do that are different from large arteries? Any ideas?
I don't know if I could. This is maybe a good topic for the panel discussion too, because I'm interested in the panel's viewpoints. I'm not a geneticist by any means, but I've been keeping an eye on the kind of genetics and proteomics and metabolomics literature, hoping that new clues might emerge from these new technologies. So, for example, from the Neurocharge Consortium, their latest paper and brain trying to integrate proteomics, DNA methylation data, genetic data, pointed to clusters of genes related to kind of like vascular media functions, related to vascular activity, lipoprotein metabolism, although as we know with these small vessel disease is not little atheromas, so the relationship with lipoprotein metabolism is I think different than atherosclerosis. But I'm not sure a clear linchpin or like target has emerged, but I'm curious what the other moderators or think. Maybe we can come back to this in the panel discussion on new targets. Thanks.
Yeah, thank you for the cue for the panel discussion. Maybe before we start the next question, I can ask Mike Sharma to join us on the stage again for the panel discussion. So we open this up again for questions regarding all presentations. And now, please go ahead.
So, Ron Lazar from the United States. So I wanted to ask Eric, because I'm glad he brought up CADASIL. One of the things that I have seen is that if you look at even young CADASIL patients and you see the T2 weighted images, you see the flare, and the white matter disease is just extraordinary, but they have almost no cognitive problems at all. And so it makes me wonder what really is the driving mechanism for cognitive decline in setting of such extensive white matter disease.
Yeah, thanks, Ron, for the question. We know these patients are at risk, right? But I think what we see is there's a reserve capacity in the brain that's able to compensate for a fair amount of white matter demyelination, before symptoms emerge. We see this with other neurodegenerative conditions too, right? So you can be older and have a brain full of amyloid, but also be functioning at a clinical normal level. So I think for me, a better understanding of this reserve capacity may be part of the answer for understanding why you can look at two patients with very similar white matter lesion load on a scan and find very different cognitive associations and consequences. So I think that's part of the explanation. White matter hypertension is also a relatively non-specific radiological sign too, right? Like it just indicates greater water content in that voxel, essentially, right? So there may be different processes underlying that, and what we consider when we look at white matter hypertensity and we tend to treat it as the same thing. The reality there may be quite different underlying processes too that are contributing to this variance.
Thank you.
And maybe I can add to this, because I think what you just said, there's data for that, especially coming from the group in Paris of Hugues Chabriat, that indeed we seem to have different white matter hyperintensities in CADASIL, which is also the reason why we don't see a strong association with white matter hyperintensities and cognition in CADASIL that we do see in sporadic small vessel disease. So there seems to be a major difference there.
So if I may ask Marco then, so what is it, the lacunes and atrophy that are the kind of the signatures of when cognition is declining in CADASIL, or what does correlate better with cognition in CADASIL if not the white matter hypertensities?
The best correlation you see for metrics from diffusion MRI, and it seems that there are also white matter hyperintensities that do not really cause a major change in diffusion metrics. So disentangling a little bit the different white matter hyperintensity subtypes maybe.
Just add to that. I think there are differences between CADASIL and sporadic small vessel disease, but in the end, there are also some similarities, and the early stages of white matter hyperintensity development are most likely areas where there's increased fluid in the interstitial tissue before you develop permanent or more overt myelin damage. And that may be one of the reasons why, for example, there was brain shrinkage in the SprintMind group who were treated with intensive blood pressure lowering and who also got less growth of their white matter hyperintensities. So the process may be more slower, sort of more indolent in so-called sporadic small vessel disease, but there's evidence from sort of imaging studies looking at different components of the tissues that the early stages of white matter hyperintensity development involve things like areas of blood-brain barrier leakage and increased interstitial fluid, which can resolve, and therefore the white matter hyperintensities can resolve. There's a systematic review documenting resolution of white matter hyperintensities, and unpublished data as yet showing that patients whose lesions tend to reduce over time are less likely to have cognitive impairment and also less likely to have motor impairment. So I think we're thinking of this as if it's one construct, and it isn't. It's a bit more subtle than that. So sorry, we have other questions.
Yeah, hi. I'm Joantura. I'm from India. I'm a former fellow from Calgary. My question is to Dr. Eric Smith and Dr. Joanna Wadlow as well. When we see the changes already in the imaging, I think the disease has already progressed to some extent. So what about looking back, looking at the genetic milieu of the patients, because the genome-wide association studies are bringing out a lot of data, and also the endothelial damage markers like endogallin, endocan, and combining them to look at the targets to prevent them at the primary level and targeting some therapy before they actually appear in the imaging. And especially when the endothelial damage, the dynamics of the perivascular space are happening before it's showing up in the imaging studies.
Yeah, I can comment on that. A multi-decade-long disease process brings both like opportunities as well as challenges, I think. The opportunity is that if we can reliably identify these processes early, we can intervene before clinical decline has occurred, right? Or at a very early stage of clinical decline. So that's the promise. I think the challenge, of course, well, two challenges in our field. Like one is finding what the right target is. And the other challenge is how operationally do you do clinical trials at this early stage, right? Like what's your outcome marker? You're probably looking at some kind of surrogate marker, but you may be looking at like large sample sizes or have to follow people for a long time. So I think that's the challenging part, you know, of a disease process with such a long latent stage. And what do you think, Dr. Wardlaw?
I think it kind of goes back to an earlier question about what is causing the endothelial dysfunction. And actually, I don't think we have a genetic marker yet that we can use to pinpoint in an individual. This is not a monogenic disease. This is a disease where there are a combination of different, possibly individually quite minor genetic variations. But if you get the lot put together, then you're more likely to have an endothelium which is more vulnerable to then being exposed to high blood pressure or whatever. And in relevant experimental models, but also some evidence in human tissue, this is an intrinsic cell-autonomous endothelial dysfunction. This is not simply a response to being exposed to high blood pressure or other, vascular risk factor. This is something which people who have this condition and are vulnerable to the condition are sitting ducks for developing the brain lesions. There are some evidence from GWAS, but mostly they're looking at clusters of genes that we don't really fully understand the function of yet. And there is also some evidence of things like methylation effects, which might be one of the explanations for the relationship between early life factors and late life higher risk of having vascular lesions in the brain. So I don't think we're quite at the stage yet of doing a single genetic test. I think we've ignored potential contributions from lipids. One of the defects which we identified in a preclinical model by going backwards from an inbred model was a flippase in the cell membrane, and it's a phospholipid flippase, and this translates to proteomic data from large-scale studies showing differences between males and females in phospholipids. And of course, lacunar stroke itself appears to be more common in males. So it's kind of all converging, but it's not quite got there yet. I don't know what other people think.
Okay. Thank you.
That's very polite.
Chris, you were first, yeah.
Oh, I thought Phil was first, but never mind. I'll take my chance. Christopher Chen from Singapore. So thank you very much. I'd like to ask the panel that now this issue of covert strokes has been brought up and that may have different mechanisms. What does the panel think is the best modality for detecting these covert strokes? Do we have to repeat DWI at multiple intervals? Did all these trials that Mike described, have we missed this opportunity?
So, Chris, thank you for that impossible to answer question. I think it depends a little bit on what you're looking at. So if our goal is to prevent cognitive decline from covert vascular disease in the population, we will need to sample a large number of them. So in that Rotterdam cohort I showed, diffusion restricting lesions were only in 1.3% of that cohort. So you'll need a very large number of patients to pick these up. By the way, in my clinical practice, when I see this incidentally, a diffusion restricting lesion, I treat those people as if they've had a stroke. I don't know if I'm right in that, but it seems to me to be a different beast than white matter lesions or even cavitations that we see chronically. Where we've studied them in a trial like axiomatic, where it was very soon after a symptomatic index event, the majority of those lesions were diffusion restricting. And with the assumption that the mechanism may be similar in those patients, that may be where to start, where you have a large number of lesions that you can target before you go to broader populations.
Thanks, I would agree. We've done studies looking at the rate of these DWI incidental lesions in different populations, and they're really much higher in people with already pre-existing cognitive impairment. Thank you.
Maybe one more. I think perhaps one more question, and then our time is up. Sorry.
My name is Jillian McKeeman, and I'm from here in Canada. But Dr. Smith, I was just wondering if breastfeeding was considered as a variable in any of this research, and if not, would it be in the future?
Yeah, that's a great question. I didn't find any studies that had looked at breastfeeding and risk for later life small vessel disease. I'll ask Dr. Wardlaw as well, because she, with Ellen Backhouse, she's reviewed this literature quite recently. Did you find anything?
It was something that was quite difficult to look at because it's partly generational, partly socially determined, and we didn't have good records. And, you know, you're asking the individual themselves, not their parent, what happened. And a lot of people might know their birth weight roughly, but they generally don't know a lot about whether they were breastfed or not. So we, unfortunately, in those studies that we had access to, we don't have good information. But I have a colleague, James Boardman, who is the co-author. He's initiated a new cohort, which is now 5 years old. So maybe in another 60 years, we might have an answer.
Thank you.
Yeah, and that wraps up the session. So thank you all for attending and for the great discussion. Have a nice day.